Hey everyone, welcome to my channel where we'll dive into all things health, medicine, and pharmacy related. Today we're tackling something that might seem simple at first, coughs. But trust me, there's a lot more to it than you might think. From the science behind why we cough to the best remedies and when to seek medical advice, we've got it all covered. So grab a cup of tea, get comfy, and let's get into it. Alright, let's talk about coughing. We all do it. But as future doctors and pharmacists, we need to do more than just recognize it. We need to diagnose it, treat it, and know when to worry. Coughing is one of the most common symptoms that bring patients into clinics, hospitals, and pharmacies. In the UK alone, it accounts for over 12 million GP visits every year. Pharmacists handle even more, 24 million. But here's the thing, coughs aren't all that the same. Some are harmless, some are serious, and some are major red flags for conditions like lung cancer, heart failure, or tuberculosis. So how do we tell them apart? In this video, we're breaking down everything you need to know about coughs in a way that's easy to understand, remember, and apply in real clinical practice. So what will we cover today? First, we'll talk about how the cough reflex works, because let's be honest, that's a classic exam question. Then we'll cover the different types of coughs so you can diagnose them correctly. After that, we'll go through the most common causes of cough, from simple viral infections to serious conditions like lung disease. Then we'll talk about red flag symptoms, when a cough isn't just a cough and needs urgent referral. We'll also cover the best evidence-based treatments using the latest guidelines. And finally, we'll apply everything we've learned to real-life patient cases, because theory is great, but if you can't use it in practice, what's the point? This is going to be your go-to guide for mastering coughs. So let's get into it. Coughing isn't just a noise. It's a complex protective reflex that keeps your lungs clear and prevents infections. It happens in 3 key phases. Step 1, irritation and stimulation. Inside your airways, your pharynx, larynx, trachea, and bronchi, you have special receptors called mechanoreceptors and chemoreceptors. These act like security guards detecting anything that shouldn't be there. This could be smoke, dust, mucus, bacteria, or even acid from your stomach in cases of reflux. As soon as they sense irritation, they send an alert to your brain. Step 2, neural transmission. The receptors send a signal via the vagus nerve and superior laryngeal nerve to the cough center in the medulla of your brainstem. This is where your body decides, do we cough or can we ignore this? If the irritation is strong enough, the brain sends a message back down to the muscles involved in coughing, telling them to get ready. Step 3, expulsion. The diaphragm and intercostal muscles contract, generating high pressure in the chest. The glottis, the opening of the larynx, closes for a split second, trapping air. Then, suddenly, the glottis opens and air is expelled forcefully at speeds of up to 500 miles per hour, clearing the irritant from the airways. And that's why coughing is such a powerful defense mechanism. It's not just noise. It's an explosion designed to keep your lungs clean. Now that we understand how a cough happens, let's classify it. Coughs come in different types, and identifying them is a key to diagnosis. First, we have a productive cough, also known as a chesty cough. This means the cough is producing sputum or phlegm, and the body is actively trying to clear mucus from the lungs. This type of cough is usually seen in infections like bronchitis and pneumonia, but it can also be present in chronic lung conditions like COPD and bronchiectasis. Then we have non-productive coughs, or dry cough. This is when there's no mucus, just an irritating, tickly sensation. Dry coughs are often caused by viral infections, asthma, gastroesophageal reflux disease, or even side effects of medications like ACE inhibitors. So one of the first questions we ask a patient is, are you coughing up phlegm, or is it just a dry, tickly cough? Because that one simple answer can point us in completely different diagnostic directions. Next we ask is, how long have you had the cough? Because the duration of the cough tells us whether we're dealing with an acute, subacute, or chronic condition. If it's an acute cough, less than 3 weeks, it's most likely viral. If it's subacute, between 3 to 8 weeks, it could be post-viral or something like asthma. And if it's chronic, more than 8 weeks, we have to start thinking about serious causes like COPD, lung cancer, or tuberculosis. If the cough is productive, we need to ask about the color and consistency of the sputum. This tells us a lot about whether the cause is bacterial, viral, or something else entirely. Clear or white sputum is usually seen in viral infections or allergies. Yellow or green sputum suggests a bacterial infection. Thick, sticky sputum could indicate asthma or COPD. Blood-streaked or rust-colored sputum is a red flag for serious conditions like tuberculosis or lung cancer. The timing of a cough also gives us diagnostic clues. Did it start suddenly, or has it been building up gradually? A sudden onset cough could be due to an infection or inhaling an irritant, while a slowly progressive cough might indicate something more chronic, like COPD or lung fibrosis. Smoking? This is a big one. Smoking is a leading cause of chronic cough. If a patient is a smoker and has had a persistent cough for more than 8 weeks, we need to rule out chronic bronchitis, COPD, and lung cancer. If the patient is a long-term smoker, ask about how many packs a year they've smoked. This helps us assess the risk for serious lung diseases. Then we have to ask about other symptoms that we could indicate a serious underlying disease. We're specifically looking for red flag symptoms like coughing up blood, unintentional weight loss, severe breathlessness, or persistent fever and night sweats. If any of these red flags are persistent, the patient needs urgent referral. In the next part of this video, we're going to cover the best evidence-based treatments for cough. We'll look at what actually works, what doesn't, and how to tailor treatment based on the cause of the cough. We'll also go through real-life patient cases so we can apply everything we've learned in a clinical setting. So stay tuned and let's keep learning. Now that we've taken a complete history and assessed the patient's symptoms, it's time to talk about treatment. And this is where things can get tricky, because not every cough needs medication, and in some cases, the wrong treatment can make things worse. So we're going to break this section into 2 parts, dry coughs and chesty coughs. Then we'll go into age appropriateness, safety considerations, and prescribing guidelines to make sure we're using the right medications for the right patients. Treatment for dry cough. A dry cough is irritating, persistent, and doesn't produce mucus. The goal of treatment here is to suppress the cough and reduce irritation. The main medications used are cough suppressants, also known as antitussives, which act on the brain's cough center in the medulla. The 2 main types of cough suppressants are opioid-based and non-opioid-based. Opioid-based suppressants like codeine, fulcodeine, and dihydrocodeine work by acting on opioid receptors in the brain to reduce the urge to cough. These drugs are effective, but they come with significant safety concerns, including respiratory depression, sedation, constipation, and dependence. According to MHRA and NICE guidelines, codeine should not be used in children under 12 years old due to the risk of respiratory depression and opioid toxicity. In children between 12 and 18 years old, codeine should also be avoided in patients with asthma, COPD, or sleep apnea, as it can worsen breathing problems. For adults, codeine should only be used for short-term relief of dry, distressing coughs and should be avoided in patients with a history of opioid dependence. A safer alternative to opioid-based suppressants is dextromethorphan. This drug is an NMDA receptor antagonist that also acts on the cough center in the brain but does not cause respiratory depression. Dextromethorphan is widely available over the counter and is generally well tolerated, but it does have misuse potential. High doses can cause hallucinations and disassociation, which is why it's sometimes abused as a recreational drug. Dextromethorphan is not recommended for children under 6 years old, and caution is advised in children aged 6 to 12. For patients who prefer non-medicated treatments, demulcents like simple linctus, glycerol, and honey can be effective for soothing an irritated throat. Honey in particular has been shown in studies to be as effective as dextromethorphan for relieving nighttime cough in children over 1 year old. However, honey should never be given to infants under 1 year old due to the risk of botulism. Treatment for chesty cough. Now let's move on to treating a chesty cough, also called a productive cough. The key here is that we do not want to suppress the cough. We want to help clear mucus from the lungs. For this, we use 2 types of medications, expectorants and mucolytics. Expectorants like guaifenesin work by increasing the volume of airway secretions, making mucus thinner and easier to clear. However, the evidence for expectorants is weak. While guaifenesin is widely used, studies have shown limited effectiveness in acute coughs. Staying hydrated is just as effective, so we should encourage patients to drink plenty of fluids. Guaifenesin should not be given to children under 6 years old, and caution is advised in children aged 6 to 12. Mucolytics like carbocisteine and acetylcysteine work by reducing the viscosity of mucus, making it easier to clear from the lungs. These are particularly useful for chronic conditions like COPD and bronchiectasis, where mucus buildup is a major problem. Carbocisteine is a prescription-only drug, and acetylcysteine is commonly used in hospital settings. They are generally well tolerated, but in rare cases, they can cause bronchospasm, so they should be used with caution in patients with asthma. Combination cough medicines. A common question patients ask is, should I take a cough syrup that has multiple ingredients in one bottle? The answer is, it depends. Many over-the-counter cough medicines contain a mixture of expectorants and cough suppressants and a decongestant, but this doesn't always make sense. For example, combining a cough suppressant with an expectorant is illogical. One is trying to suppress the cough while the other is trying to make the cough more productive. So a good rule of thumb is always target the main symptom rather than using combination products. If the patient has a dry cough, use a suppressant. If they have a chesty cough, use an expectorant or a mucolytic. And if they just have a sore throat, simple linctus or honey may be enough. Now that we've covered the science, let's apply everything we've learned to real patient cases. This is where we take theory and turn it into a clinical decision making. So I'll present a case and I want you to think about what's going on and how we should manage it. A 35-year-old woman comes into the pharmacy complaining of a persistent dry cough for the past 5 weeks. She has no fever, no weight loss, and no shortness of breath. However, she mentions that she recently recovered from a cold about a month ago. She is otherwise healthy and takes no regular medications. What's the most likely diagnosis? This is most likely a post-viral cough, which can persist for several weeks after a respiratory infection. This happens because the airways remain irritated and hypersensitive even after the virus has cleared. So how do we treat it? First, we reassure the patient that this type of cough is self-limiting and will resolve on its own. Second, we can recommend demulcents like simple linctins or honey, as they can soothe throat irritation. If the cough is particularly bothersome at night, we might suggest a short course of a non-opioid cough suppressant like dextromethorphan. What do we not do? We do not give antibiotics because this is clearly viral and antibiotics won't help. And we do not prescribe a mucolytic or an expectorant because there's no mucus to clear. Case 2. A 25-year-old man presents with a recurrent nighttime cough and an occasional wheezing after exercise. He has no fever, no sputum production, and no history of recent infections. However, he mentions that his symptoms are worse in cold weather and after exposure to dust. He has a family history of asthma. What's the most likely diagnosis? This is cough variant asthma. Unlike classic asthma, which presents with wheezing and breathlessness, cough variant asthma presents mainly as a chronic dry cough that is worse at night and triggered by allergens or exercise. How do we manage this? The first step is to confirm the diagnosis using a spirometry or a peak flow test, looking for reversible airway obstruction. If confirmed, we treat with a trial of inhaled corticosteroids such as beclomethazine combined with a short-acting bronchodilator like salbutamol for symptom relief. What do we not do? We do not give codeine or dextromethorphan because the problem isn't irritation, it's airway inflammation, and that needs to be treated with an inhaler. Case 3. Now let's look at a different type of case. A 42-year-old woman complains of a chronic dry cough that's worse at night and after meals. She also experiences a burning sensation in her chest after eating spicy food. She's otherwise healthy and doesn't smoke. What's the most likely cause? This is gastroesophageal reflux disease induced cough, also known as GORD induced cough. The cough is caused by acid reflux irritating the throat and often triggering the cough reflex. This is often worse at night when the patient is lying down, and it can also be triggered by certain foods such as spicy or fatty meals. How do we manage it? The first step is lifestyle modifications. Advise the patient to avoid eating late at night, reduce caffeine and alcohol, and sleep with the head of the bed elevated. If symptoms persist, we can prescribe a proton pump inhibitor like omeprazole or lansoprazole to reduce acid production. What do we not do? We do not give cough suppressants because the problem isn't irritation, it's acid reflux, and that's the need to be controlled. Next case. A 60-year-old man with a 40-pack a year smoking history presents with a chronic productive cough lasting 6 months. He produces thick white sputum every morning but denies fever or weight loss. His cough worsens in cold weather and he gets short of breath on exertion. What's the most likely diagnosis? This is chronic bronchitis, a form of COPD, chronic obstructive pulmonary disease, that leads to a long-term mucus production and airway inflammation. The persistent morning cough with sputum production is a classic sign. How do we manage it? The most important step is smoking cessation. No treatment will be effective if the patient continues smoking. We should also perform spirometry to assess lung function and confirm COPD. Treatment usually includes inhaled bronchodilators like tiotropium or salmeterol, and if symptoms worsen, we may consider adding inhaled corticosteroids. What do we not do? Do not give cough suppressants because suppressing mucus clearance in the COPD patient can lead to mucus plugging and infection. Final case. A 65-year-old smoker presents with a persistent cough lasting 3 months. He has lost 5 kilograms in the last 2 months. He feels consistently fatigued and has occasional blood-streaked sputum. He denies fever or night sweats. What should we do and be most concerned about? This is a red flag case, highly suspicious for lung cancer. The combination of chronic cough, weight loss, hemoptysis, and fatigue requires urgent referral for a chest x-ray and a CT scan. What do we not do? We do not waste time with over-the-counter cough medicines. This patient needs immediate investigation to rule out malignancy. So that brings us to the end of this comprehensive guide on coughs. We've covered everything from the basics of how the cough reflexes work, to history taking, differential diagnosis, red flags, treatment options, and real-life patient cases. By now, you should feel more confident in assessing a patient with a cough, knowing when it's harmless, when it needs treatment, and when it's a red flag requiring urgent referral. Just to recap, the key things to remember are: firstly, always take a structured history. Ask about the duration, the sputum production, the onset, smoking history, associated symptoms, and red flags. Second, tailor your treatment to the type of cough, suppressants for dry coughs, expectorants for productive coughs, and specific treatments for underlying conditions like asthma, reflux, or infections. Third, be cautious with medications. Avoid codeine in children. Be aware of potential misuse of dextromethorphan, and educate patients about realistic expectations of cough medicines. Fourth, not all coughs need antibiotics. Most are viral and resolve on their own with symptomatic relief. And finally, recognize red flags. Coughs with hemoptysis, weight loss, persistent breathlessness, or night sweats should always be referred for further investigation. I hope you found this video helpful. If you did, don't forget to like, subscribe, and hit the notification bell so you don't miss out on the future content. Also, if you have any questions, drop them in the comments below. I'd love to hear your thoughts or any topics you'd like me to cover next. Thanks for watching, stay curious, and I'll see you in the next one.